Recording in progress.
Hi, good evening, good morning, and good afternoon, depends on where you're from. A very warm welcome to all of you for joining us today for the 5th TUGS Asia Symposium. As usual, I'm very honored today to have a great team of faculty in joining us to share the latest updates on metabolic and bariatric surgery, back to the basics. So probably let me just first go through the panelists today. First, we have Dr. Aparna Govashka. She is the consultant bariatric and laparoscopic surgeon based in Shaifi Hospital and Apollo Spectra Hospital in Mumbai. She is also the newly appointed TUGS Women Coordinator, and I'm sure she has many plans ahead for the TUGS Women's community. She is also the committee member of a few local as well as international obesity association. So she has numerous publications as well as she's the author for a few books chapter. And I would also like to take this opportunity to congratulate Aparna for being voted as one of the top 100 doctors in Mumbai India Today Health magazine. Aparna, would you want to say hi to the audience?
Hi, everyone, and thank you so much, Dr. Kelvin Boone, for the kind introduction. Hi, everybody, and I'm sure we're going to have a very interesting...
Aparna, maybe you can unmute yourself.
I am unmuted. Can you hear me?
Are you able to unmute yourself, Aparna?
I am...
We can hear you.
Okay, it's okay. Maybe I'll go on with the next one after this. Okay, we'll sort this out later. Apologies of the mistake. So the next panelist I have with me today is Dr. Bijis Madok. He is the consultant upper GI and a bariatric surgeon from Royal Derby Hospital in UK, and he is also the honorary assistant professor at the University of Nottingham. He's of course our TUGS Lounge coordinator who has been organized and overseeing the exciting academic activity monthly via the TUGS Lounge academic forum. Dr. Bijis, you want to wave to the crowd, perhaps?
Thanks, Kelvin. Thank you so much for the kind words. Hello, everybody. Looking forward to the session. I'm sure we'll have fun today.
I think you are muted. Let me just sort this out for a while. Just give me a minute.
I'm unmuted, Kelvin.
Yeah, we can hear him.
Yeah, Kelvin, we
you
could hear Aparna as well.
Right. Okay.
Yeah.
So lastly, we have Dr. Mohammad Haisham Elfawa with us. He is the consultant hepatobiliary and bariatric surgeon from Makassar General Hospital and BSC Health Center in Lebanon. He is the current president of the Pan-Arab Society of Bariatric and Metabolic Surgery. He is also the TUGS Middle East coordinator. And of course, he is a pioneer in performing bariatric surgery with a paravertebral block in the world. Welcome, Dr. Mohammad Haisham. Maybe you want to say a word of hi to the crowd.
Hello, everyone. Thank you, Kevin, for the presentation. I would like to welcome you all for the 5th TUGS Asia meeting. Hope to have a fruitful meeting, inshallah. Thank you so much.
Thank you for the very warm welcome to all three panelists. And so before we kickstart the event today, just a couple of housekeeping rules to announce. Number one, as you notice, you have been muted as you enter the TUGS Symposium function today. So along the way, if you have any questions, feel free to put in your questions via the chat box function, and we shall keep the questions until the Q&A session at the end of the presentations. Number two, as you notice also, this symposium is being recorded for internal use. So your participation actually serves as a consent for us to record you for future replay. So without further ado, I'll pass the stage to the panelists and the speakers today. So we'll have Dr. Bijis Madok to introduce the first speaker for us today. Bijis, the mic is yours.
Thanks, Kelvin. So everybody, we have a fantastic speaker with us, Dr. Nidhi Khandelwal. She is a GI and a bariatric surgeon trained in minimally invasive surgery. After completing her MBBS from Grant Medical College, Mumbai, she pursued her specialty degree in general surgery from Bombay Hospital. Nidhi passed her MS General Surgery as the university topper of the batch of 2014 and has been practicing metabolic surgery since 2015. She holds the post of convener of the Young OSSI, which is Obesity and Metabolic Surgery Society of India. She is currently affiliated with Jaslok and Nanavati hospitals in Mumbai, India, as a consultant surgeon. Nidhi, thank you so much.
Thank you, Bridge, and thank you, Kelvin, for organizing this whole thing today and helping me and Dr. Abhishek put together this esteemed line of panelists for us today. Good evening, good morning, and good afternoon, everybody, from wherever you're joining us. Like Kelvin said, you know, TUGS is a really good platform today for us to discuss more and more about upper GI surgeries. And this is the 5th one which is happening here. And in the past, we've discussed some really complex issues like gastric cancer. So moving on from some really morbid topics to a really happy topic. You know, bariatric surgery is generally a very happy surgery because whenever patients lose weight, everybody's always happy. So going back to the basics of bariatric and metabolic surgery, I think one of the first things which comes to anybody's mind is not just how to train in it, but also how you're supposed to set up your own unit. What all do you need as a backup? What all do you need to plan for in your future? And that is why this is the first topic that we've all selected. Understand this, that when you talk about a bariatric unit, we are not just talking about surgical weight loss. A bariatric unit is something which has to cater to weight loss in every possible way. So it will also include a medical weight loss and also will include a metabolic clinic and also rehab in terms of physical therapy, nutritional therapy, and also psychosocial therapy. So a bariatric unit, if it has to be completely wholesome, is something which has to cater to all of these services. So think about it from a patient's point of view. The surgeon has to be very approachable. A nutritionist has to always be available for you. Safety is a big concern, of course, for the surgeon as well as for the patient. Privacy can be an issue because many people don't want to reveal that they've undergone a weight loss surgery. And more importantly, whenever a patient walks into this kind of a clinic, they want it to be a stigma-free environment where they don't want somebody to come and raise fingers at them that, I'm obese and, I may be judged for being such a big foodie, having so many junk food habits, etc., etc. It has to be something in which they feel comfortable, where they feel safe, and where they feel that, yes, they can achieve whatever are their physical therapy goals that they have planned for. So it has to be a very seamless experience for them. And to make it so, you need a very good staff support. Your staff has to be very well trained. They have to always be there to guide the patient, and they have to have this whole friendly vibe, but you don't want to make it feel more like a hospital. Many people are really scared of hospitals. You don't have to make it feel like that. You just have to make it feel like a second home for them, where they can just come to with their problems and you can work through things with them. At the same time, you as a surgeon will want a really good team backing you up. You will want a good associate surgeon. You will want a good nutritionist, a physiotherapist. You will need a good endocrinologist or your physician support, basically a full multidisciplinary team which can back you up very well. And you will also want to have a very well-equipped OR and an ICU, apart from your wards and clinic, obviously. What the hospital eventually wants with, when they invest so many resources in you, is that you provide them with really good outcomes in terms of morbidity and mortality. Because once your M&M numbers are low, your patients are happy, they are the ones who are going to go out and are going to advertise these good outcomes in the public. This is how your unit will grow in the future, because a patient is always the one who's going to bring in another patient. And once the hospital sees that a unit is doing well, the patients are happy, they're getting better, they're satisfied, that is when the hospital will start investing more and more in its growth. And that is how you will get more research grants, and then you will be able to progress even further. Now, at the core of any bariatric program, of course, is always going to be the surgeon, whether you're talking even about medical weight loss. A surgeon is somebody who has to be very well versed with all your GI physiology, all metabolic diseases, and also nutrition. I mean, follow those nutritional guidelines yourself, practice what you preach. You can be an inspiration for your own patients that way. And should be very well trained in laparoscopic surgery, should be trained at a very high volume center so that you have seen enough diseases, enough wide variety of cases, and you also know how to handle multiple complications as and when they may come your way, because you cannot wait to start off your own unit and then wait to handle a complication. So take your time, invest your time in training very well, stay there for like 2 years, 3 years. There are many certified courses also now for bariatric surgery. So make sure that you get into one of those, train properly, and keep learning. That is the most important thing, because if you want to keep looking at your colleagues for inspiration rather than being, feeling defeated by them, that's the only way you will be able to progress in your own life. Keep getting inspired from others, design your own protocols, and accordingly just come up with your own system. Eventually, do make sure that you're affiliated to your National Obesity Surgery Society. Practically every country today has one. If not that, then at least if so. And once you are in the mix of things, once you're meeting colleagues regularly, and via symposia like this, via the TUGS platform also, you will be able to understand and learn more and more about your field, little things which you can always pick up from everybody else. And at the end of the day, you should learn how to be a good leader, and you should be very compassionate towards these patients. Because once again, they're not people who are coming to you as such with just a disease per se. They're the ones who are coming to you with a lifestyle issue. They're going to come to you very concerned about their weight. And if you are just going to tell them bluntly, no, you're obese, you need a sleeve, they're not really going to be able to understand it that much. You have to be really compassionate towards them, understand their issues, work through all their issues, counsel them very well, and then eventually help your team also to help your patients get better. Select the right institute in which you want to eventually practice. It should be a tertiary care center, no doubt about it, because you do need a multidisciplinary team, because you have to collaborate with all of them. They are the ones who are going to send most of your patients to you, and you will also be sending your patients back to them. There's always going to be a back and forth, as is with all fields of medicine. Have a good SICU at a casualty backup in all of these places, because you have to be approachable 24/7 for all your patients. Make sure that the infrastructure which is there in all these institutes is bariatric friendly, as in the bed capacity should be enough. They should be having a good chairs with a good armrest, and the doors should be wide enough in such that the patient should not feel constrained in any way. It should be easy enough for their regular movement so that they're actually more active. Eventually, like I said before, if the hospital sees that you are giving rise to good results, they will end up supporting you with better marketing, and that is what will help your practice grow even further. Whenever you go and select a good institute where you want to practice, check out the operating room and the wards. Make sure that it's all spacious, that there are very good staff personnel, train these staff yourself, develop a good one-to-one relationship with them so that they understand you better and you understand how they function, because eventually it's all about teamwork. It's like an orchestra. It has to play in synchrony. Have a good post-op recovery and an SICU bed, and also make sure that your resident doctors and fellows, whoever are there in training, they are also, very well adept in picking up even the smallest of disturbances which may happen in a post-operative case, because a bariatric patient can crash really suddenly and you don't want a delay in diagnosing any of these issues. Now, any nutritionist which you will hire in your team ideally has to be a bariatric nutritionist. Once again, there are multiple certified courses which are available in every country for bariatric nutrition. So this is somebody, who should just be on the same page as you, where you and she or he can get together and develop pre and post-operative dietary guidelines based on the kind of patients which you see, based on your local cultural food habits, so that you don't have to just blindly follow a trend. You come up with your own things. It should not be somebody who will just hand over a diet chart to you and say that, this is what is written, just follow it. It should be somebody who can sit again one-on-one with the patient and discuss and sort out all these small little doubts which people tend to have. Another thing which your nutritionist should be well at is picking up nutritional deficiencies. She should be able to diagnose any of these even before you do, because your patient is going to be more in touch with your nutritionist rather than with the surgeon itself. Another component, like I mentioned at the start, when it comes to a bariatric unit, is medical weight loss. So it's your nutritionist who's going to spearhead your entire medical weight loss and a weight loss plateau program, because she or he is the one who's going to formulate multiple charts based on individual patient needs. Your dietitian is the one who is going to eventually screen all your patients and is going to decide whether a particular patient is a deserving candidate for a bariatric surgery or not. And that is why your nutritionist also has to not just be trained in nutritional in the field of nutritics, but also in bariatric surgery, because once again, there's going to be a lot of overlapping in all of these fields, and your nutritionist needs to be able to handle all other queries of all patients as well. A third important person in this whole program is going to be a bariatric coordinator. Now, there are very few fields in medicine which actually require a coordinator, but bariatric surgery is definitely one of these, because this is going to be the one point of contact for all your patients. You're going to have a lot of patients, and it's going to be very difficult for you to keep track of all of them and maintain an OPD diary and maintain your operation theater diary and everything. So a coordinator is somebody who can help you with this whole day-to-day functioning. She can also help you plan support group meetings, multiple awareness campaigns, etc., and also conduct educational programs for your in-house staff, so that everybody keeps on getting updated with their knowledge and everybody knows exactly what's happening with all your patients. Overall, the development and good maintenance and good day-to-day running of the center is usually handled by a bariatric coordinator. Since this coordinator is going to be the first person your patients will all communicate with, they have to be a very good communicator. They have to be very good with their person skills, and they have to once again show the same compassion which you expect a surgeon to show. Data collection is something which has become so crucial in today's era in the field of evidence-based medicine, because you not only need to record your pre and post-op data or just your follow-up records of your patient, you also need to record the nutritional data, your cultural data, because all of these little things are since they're all responsible for the patient putting on weight, they will also help you in how to guide the patient and how to lose weight. So make sure that you have somebody who's sitting and recording all of these things. This will help you further clinically and also for any further research that you may be interested in. And very importantly, if frequently you're going to sit and keep analyzing your data with your entire team, you all can get together, brainstorm, and that is eventually how you will improve the long-term quality of your clinic, which is what the whole point of this exercise is. And once again, since we're living in the pandemic era, or rather in the post-pandemic era in some places, electronic access is very important. Whether we like it or not, healthcare has practically become virtual as well. If you don't have a website, if you don't have a social media presence, somewhere patients feel you are lacking. And so it's important for your unit to be very present even on social media. keep options open for video consultations. It's not always going to be possible for patients to physically follow up with you. And yeah, we've all seen it during the COVID era that having these options of video consultations have proven to be very fruitful. One thing about bariatric surgery, we may not always necessarily need to examine every patient, especially in the long run, maybe after a year or 2 years, especially when we know they're doing well. But at least if you're going to be in touch with them on a virtual platform or even via virtual support group meetings, it is going to help make them a little bit more aware and help them maintain their weight in the long run. Now, support group meetings are an extremely crucial part of all bariatric programs, because enough research has proven that it's long-term follow-up which actually helps in patients maintaining their weight. If you want good long-term results, the patient has to be in touch with the center. There may be ebbs and flows, but eventually, if the patient constantly stays in touch, or if you have a member of your team, for example, your coordinator, who's constantly reaching out to the patients and is motivating them, that is when you see the best results. Now, since your patients are your greatest support, you have to make sure that you're constantly supporting them. So conduct these meetings at really frequent and regular intervals. It can even be virtual, like I said, and your coordinator is somebody who will help you plan out all of these things, have a different theme for each meeting. And just these small events are what, these social events are what keep us going. Eventually, it's all about teamwork. It's a lot of people who come together in a lot of things. Everybody has to know their role, but there is always going to be a slight overlap. For instance, as a surgeon, you cannot say that, no, I'm not going to guide you even a little bit on what you need to eat. That will be handled by the dietitian. The nutritionist will land up doing some amount of psychological counseling. The psychologist will land up, just telling you what kind of physical exercises you can do in order to feel better. All of these little things are there, but eventually, all of you have to collaborate together. Make sure that everybody is reporting to one person. Usually in this case would be the surgeon, and everybody should be equally responsible for patient care. One person should be covering up for another, and maintain a really good harmony between all of these team members, because this is also your family. You do spend 8 to 10 hours at work every day. You are spending just as much amount of time with them as you are at home. So make sure that everybody is on the same page and are in good synchronization with each other, because once we are in sync, that is when even the patients will go through the whole flow of weight loss in very good order. Lastly, once you have enough cases under your belt, once you're doing really good quality work, you need to apply for an accreditation as a center or a surgeon of excellence. There are multiple such programs. Again, most of these are affiliated with your National Obesity Surgery Society. In India, of course, for us, it's OSCE, and everybody knows about ASMBS and now IEF as propagated very often. So this is what is very important eventually in the long run for your center to function very well. So if the surgeon is well trained and is a good leader, if you have a good team in place, if your hospital supports you by seeing really good outcomes and your patients are happy and they're bringing in more patients, that is when you will run a good, successful bariatric unit. This is something which you can only develop over a period of years. This is something which you can only develop when you yourself have trained at a very good center, where you can see their day-to-day functioning and pick up these small nuances from your current leader. Find this perfect balance so that the hospital, the patient, and the surgeon, everybody can get whatever they want, so that eventually everybody is seeing good outcomes, not just in terms of weight loss, but also in terms of metabolic diseases and overall in terms of quality of life. That was it. Thank you, everybody. Stay safe.
Thank you, Nidhi, for an excellent presentation. I think that multidisciplinary team is a key in success in bariatric practice, and we'll keep the discussion till the end. It is my pleasure now to introduce Matt. Matt is a consultant bariatric surgeon at BMI IMC from China Medical University Hospital. He had more than 10 years experience in bariatric surgery and a lot of work in endoscopic surgery. Matt is going to talk about preoperative assessment and type of surgery. Matt, the floor is yours.
Okay, thank you for your warm introduction. Good evening, good day, and good afternoon, everyone. I'm Matt. I'm from Taiwan. So today I'm talking, I show my presentation first. Okay, here, sorry. Give me 4 minutes. I share my. Okay. Okay. So, okay. So hope everybody could see my presentation and hear my sound well. Okay, today I'm talking about the preoperative assessment and some types about the metabolic surgery. But actually, I personally thinking I emphasize something about some experience I experienced in these few years. I think all the surgeons here already well trained surgeon. They're already in this field for a long time. So I'm more focused about something that I think a good bariatric surgeon should have when we're doing the evaluation for patients. So I'm Matt from Taiwan. So I'm from China Medical University Hospital, Taiwan, and now I work with CK. So, okay, the first. When is the time we need operation? When the time we need to offer operation for patients? Actually, there's some hints, just like guideline. Guideline tell us about a lot of things. So just like SMBS, he gives some numbers. He said, when BMI more than 40 or BMI more than 35 with comorbidities, blah, 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 with these kind of situations, when surgeons should offer a treatment like surgery for patients to control their disease or improve their status. So in the meanwhile, like if so, they correct a lot of data, a lot of hints to give us a good reference about when a patient BMI more than 40 or BMI more than 35 with disease in age between 18 to 16, long-standing diabetes or obesity, they should have operation to improve their status. So where the time goes, even in the physicians, they also tell their physician, the doctors that when patient in high BMI or with the obesity with poor control of diabetes, actually you should tell the patient that there's something more than medication. There's something about surgery that could also improve your disease status. So in Taiwan, currently in our center, we use the consensus about the IPSO APC in 2011. It's about when patient BMI more than 35 with comorbidities, or BMI 30 with diabetes, or BMI more than 27.5 with poor control of diabetes. Doctor should let patient know you got another choice, that surgery may be a helpful method to improve your disease. But is that all? I think it's hard. I think it's really hard. In the most time, the guidelines only give you a range, a hint. But so sometimes for me, I think guidelines is like a map. He show you some pathway, it would be safe, it's a reasonable pathway. But in the real situation, it's not the Bible. Surgeons need to adjust, have to decide the decision by a lot of factors, patient status, and then the disease status, to offer the best choice for patients. So it's a really hard situation. So when you stay in this field for a long time, sometimes you will start to challenge the limitation about the guidelines. So like us in the past, actually we do some surgery for the patient in slightly obese that in Taiwan is a BMI more than 24. But in our result, we find when you offer the operation in this kind of group, obese patient, not BMI is around 24, 25, 26, but they got diabetes with good pancreatic function. Actually, surgery do help for this kind of patient. But my opinion is about it. For surgeons, for teamwork hospitals, I think the guideline actually is a roadmap. It offers some good choice, some safe pathways. But when you stay here long, focus long, you start to change the limitation. But you need to know the risk and to prepare yourself and your team well. Otherwise, you will make trouble for yourself and for patients. So in each center or yourself, you should have a treatment pathway like that in our center. When BMI more than 24, like the BMI less than 27.5, you may offer diet, education, there are some teaching program for patients. You more in BMI 27.5 to 30, we offer medication or endoscope treatment like IG Botox or the endoscopic ESG treatment for this kind of patient. When the patient higher in BMI with more comorbidity, you need to offer surgery. But actually, when the patient come to our clinic, they got different kind of askings. When the female in the young lady in age 26, in the body weight around 68 or 70, actually in Taiwan, sometimes he will be treated like a guillotine, he is too heavy. He will have trouble in go to a family, get a marriage. So sometimes surgeons or your hospital need to adjust all the factors to give the best offer, best help for our patients. So sometimes you will challenge this kind of path or change this kind of limitation. But whatever, I think the most important thing is you need to know something good part, the limitation about your treatment for patient. You need to tell them what kind of risk or kind of benefit could get from the therapy. So I think it's hard to always hard to make a decision. You need to consider the need of patient. You need to consider the evidence of the science. You need to consider ability of your hospital, yourself, which kind is the best one you could offer for patients. So you need to remodel and adjust by every time. So whatever, I think, prepare yourself well and do the best thing for your patient. Just like this one in my clinic is a 51 years old male. Is average height, but he's very heavy. His BMI around 48. He already got diabetes for 3 years in OHA control, but even in this kind of situation, you know, it's not good in the diabetes control. HbA1c still remain at 0.5. So usually this kind will be remain in the physician's part. You will keep on education that you need to control your diet. You need to take medication, everything, blah blah blah. But in the situations, the patient is handicapped person, a lot of limitations comes. So sometimes I do think surgeons should need to consider every part, every aspect for patient to do the best things for them. So for my personal experience or thinking, there's something I want to share here is that just like for evaluation, I think a surgeon is just like a general in a battle. He needs to lead all the teams to win the battle. So the victory is not only a single battle win. You need to win in every part and get the final victory. So you need to arrange your team. You need to arrange everything well. You need to make your team works. A single excellent soldier could not change in the result. You need a team to do the things good. So in my clinic, usually I very for my thing, something is very important for me. That is, when patient comes, the age tells a lot of story. When patient in different kind of age, they live differently. Just like a patient comes to your clinic in the age of 30, maybe they have trouble in marriage. They could not get girlfriends, boyfriend. They could not get married. There's still no kids, so they got some time to have exercise. But when patient goes to the age around 50, maybe they are stable in family, but the problem bother them is about overweight and the diabetes, metabolic disease. So in their different kind of age, what they want is different. In different kind of country, also that's different. So I think in the surgeon in your country, you need to know in different kind of age in your patient what they want. And also something important is the family status. A lot of young patients were brought to the clinic due to the stress from their parents. So sometimes I will ask, when the young kids and the parents come, I will ask, who bring you here? The patient come by yourself or your family, your parents ask you come here. And also when the patient is adult, if they get married or not, if they got kids or not, it's important. Why? You know, when you get married and we got kids, you don't have your leisure time, you don't have free time. And also when a young, something like that, a young adult comes in the age around 18 or 19, they already got very obese. Sometimes you have to ask them if he was a grandparenting child So actually, the family dominate a lot of things. Different kind of family got different kind of lifestyle, different kind of gene. So actually, a single operation on the patient could not change everything. You need to talk to their family. You need to let their family know patient have to change some lifestyle in the future. Otherwise, the operation will not help to do their best for patients. And also occupation is important. Different kind of occupation got different kind of lifestyle. So when my job is like a banker sitting in the office, and another patient is a farmer working in the farm, I think their lifestyle is totally different. So you need to adjust the future lifestyle change for patient according to their lifestyle, according to their job. So in a clinic, usually I have to spend at least 30 minutes to talking about their family, their self, to decide which kind of surgery could offer the best result and the most suitable for their life. So I think in the recent few years, because the relationship between the bariatric patient and surgeon, the relationship is very, very long. Just like when you offer a right gauge bypass or mini gauge bypass for patient, you know you have to take care of this patient for lifelong. You know in the long term there is some complication will happen. So I think it's better to get more information from the patient in the beginning. Give them the best choice. Okay. So another thing important is the body composition analysis. In Taiwan, in our center, we use the in-body machine. This machine coming from Korea. So sometimes I will make joke. So without this kind of body composition machine, I could not have a good evaluation to patient. And in this kind of data, I could know a lot of stories for patients. So in the right side is a phone in our center, but usually what I look is the age. Different kind of age got different kind of lifestyle. Then I will check the body height, body weight, and then I got the BMI. So I could know patient is the normal in BMI or obese or morbid obesity. So then you will know different kind of pathway or treatment. But there's two things I will always emphasize to patient. That is, I will always check the skeletal muscle mass and the percentage of body fat, because these two things could tell you the secrets about patient's daily life. Just like Taiwan, if patient is in Taiwan, if female patient age around 50, in this kind of 100 nearly 160 centimeter body height, usually this kind of 19.6 kilogram skeletal muscle mass is not sufficient, really. That means sometimes their daily activity not so good. Maybe they don't have a regular exercise habit. And you can see the percentage of body fat is high, is more than 35. So in Taiwan, this kind will be treated as a puff man, a puff lady. That means not so obese, but he looks obese because a lot of fat inside in his body. And also you can see the segmental limb analysis. In this kind of, when you see the trunk, you will get some hint if the patient is daily activity is good or not, if he got the exercise in usual time or not. But in this kind of analysis, if patient have work, you know maybe she's sit on a chair for a long time. It's office lady work. And also in a long-term analysis, you could see the body composition history. When you analysis the weight, skeletal mass, or body fat percentage, you could know the patient doing good or not in the after the operation. But I think in different kind of country, they got different kind of lifestyle, different kind of food, different kind of favorites about the body weight and the body shape. So I would deeply suggest you need to have your surgeon, your own database about in the patient, like in Malaysia or in India, what is the normal ratio look like? What is the normal skeletal muscle mass? What is the normal in the percentage body fat? Then you could, when you know something secret about it, the patient will trust you a lot. So something like that is a very interesting story. This data coming from a sister, a sister. They're only 2 years in difference in age. They are all the kindergarten teachers. But you know, one is heavy, nearly 100 kilograms. Another one is not so heavy, but still obese. But you guess what? In the left side, this one, the sister, the elder sister, she focused a lot. She tried to lose weight and join the gym exercise, do a lot of exercise, but unfortunately heavier than her younger sister. But what's the difference? She got a better skeletal muscle. So sometimes I tell these sisters, what the difference in the future if both of you have operations, your elder sister will have a better shape in the future because good muscle. So when we be able to control her body fat, actually she will have a nice, good shaping in the future. But for the younger sisters, her skeletal muscle mass not so good. The percentage not as high as her sister. So even she could have a good weight loss, but in the looking outside will not as good as her sister does. So for that, I think just before go to the exam, I think this kind, when you're talking about have a to the patient to their life, when you could get some more information from this kind of body composition analysis, I think patient will trust you all and will be in the future will got very good relationship. So again, when we go more advanced, I think before operation, some basic lab data and basic exam we need to offer. So I will not emphasize a lot. So some basic blood tests check liver, renal, thyroid function, or lipid profile, DM profile is important for this kind of patient. But for DM profile in our center, we always check the blood sugar, glycoprotein, and also the pancreatic function C-peptide. And we also check insulin sensitivity and resistance, because this kind of data give a lot of hint about the future after the surgery, about their diabetes changing. And for another basic exam about panoscope, liver echo, bone marrow density is a routine exam in our center. So the reason we need to do the echo is first, we need to see patient got the fatty liver, hepatitis, cirrhosis, hepatoma or not. We need to exclude some liver disease, especially for some countries, they still got a lot of hepatitis. But also important is about for gallstone. After the operation, when the rapid weight loss comes, the gallstone sometimes will become more severe. So after the operation, after 3 months, when gallstone comes, it will hard for you to know what happened. So in our routine, we will do the evaluation before operation. When patient got a gallstone symptomatic or more than 1 centimeter gallstone, we will do the concomitant lab coke in the same time. And another issue is about the panoscope GERD. Because in our center, we routinely do panoscope for every patient who needs to operate bariatric surgery. So we need to know patient got the ulcer, hernia, or GERD or not, because they would have some effect about our choice of surgery. So in the same time, because in the recent 2 years, two medical society already released their statement about the issue about panoscope. They all already suggest the routinely pre-op panoscope exam is very important, especially when patient got bariatric esophagus. You need to treat it before the surgery and carefully choose operation for this kind of bariatric esophagus patients, because in the long term there may be something wrong in the future. So, and also in our center, we also offer, we need to do the bone marrow density exam for patient. Actually, although patient is obese, sometimes their bone density is high if the patient is obese since a young child. But mostly when patient get obesity after adult, sometimes their bone marrow density is not so good. When you offer some malnutrition operation like right gastric bypass or mini gastric bypass or even BPD DS, this surgery, the long-term vitamin insufficiency will be very severe. So you need to know the basic data and do the replacement after surgery well. So actually, I think in the first part about I will do and I will suggest to emphasize more about your patients. So my deep suggestion, you need to know your patient well. You need to use a language they understand to explain what you want you to do. Because I think for weight loss or improving of the metabolic disease, I think our final purpose or destination is change the lifestyle of patients. The surgery could only change the organ, but you need education to change the thinking about patients. So you need to have spend some more time on your patients to let them know what you want you to do. When they agree, when they know that they will go to the pathway you offered, then everybody will go happy in the future. So in the second part is about the metabolic operations. I would some concept I would say. I think in the past we think about the bariatric surgery is the surgery that could make patient eat less or absorb less or do it at the same time. But so and therefore there's a lot of theory about foregut theory, hindgut theory talking about the effect of the surgery, and also some model being proposed talking about after surgery why this kind of metabolic disease could be resolved. But I think in this kind of time in this few years, I think the surgery bariatric surgery itself should be renamed as metabolic surgery. And also, this kind of surgery is not only about changing this energy transferring system, not only changing about the stomach, only changing the gut. I think the current concept about the metabolic surgery is about changing the gut and changing the brain. Because a lot of analysis and study talking about when after operation, our brain function will change, our conception will change. Because the brain-gut axis, when you do something change about the GI system, actually change the whole human body, including the hormone, including appetite, including the adipose tissue, bile acid, insulin resistance, everything changed. But I think all these kind of changes is about changing the whole system, not the organ. I think in the past for general surgery surgeon, our concept is that we offer surgery to change the organ and change the disease. But I think for the metabolic surgery, it's about you offer a surgery, change the organ, but your purpose, you want to change the whole system, change the patient's life. It's different. So every change coming after the bariatric surgery. So I think it's very important idea about the concept about the metabolic surgery. The changing is for whole system, not only about a single organ. Okay. So that's just like that. I think for surgery in the past, we only want to change the size. We want to, this operation could make a big apple to a small apple. But no, I think the metabolic idea is about you need to change the content inside and also change the size about the patient. When these two things come together, then the effect will be less into a last, but not only small change in a few times. So in Taiwan, currently we offer several operations. Just the first one, the most popular is sleeve gastrectomy. So, but in our center, sleeve usually offer for the patient in BMI less than 50, and or when patients is young with diabetes, but the C-peptide still remains more than 3. If patient got grade A or B, is fine. We could do it safely, but when patient got grade D, usually if patient have a concomitant hiatal hernia, then we'll do operation. But if patient more than grade C or grade D or Barrett, usually the sleeve will not suggest for this kind of patient. But a lot of but inside is a general rule. But you know, when patient is in BMI in 47 or 46, usually the sleeve will not give a patient good best result. Just like as an example, if patient is 35 years old male with the body weight in 110, BMI around 42 or 47, usually this kind of operation could only around 40 or 45 kilogram weight loss. They usually in the 5 years later, they will still got in 80 or their body weight. So actually in the real situation is, although you sleeve could offer in this kind of good result in weight loss, but you need to know patients want to decide which kind of operation is good or not. So just like in our center's data, this kind of operation could, in the long term, could offer result around more than 60 to more than 70 accessory loss. And in Taiwanese, after the sleep, usually the body will remain around 24, 25 in this kind of status. But the issue about the sleep is the anti-diabetes effect is not as good as a mini gauge bypass or right gauge bypass do. So you need to very carefully thinking about the metabolic disease in the patient that who need operation. And another thing is right gauge bypass. Nowadays, right gauge bypass no longer look like in the past. The modern right gauge bypass is a small gauge pouch with a short gastroenterostomy with a small gastroenterostomy. But in Americans, they mostly do the 80 or 70s dense or right limb bypass or around 80 centimeters BP limb bypass. But in our center, we do it different. Actually, in Taiwan, in our center, we will keep the right limb around 100 and adjust the BP limb length according to the patient's BMI. But in the nowadays, in the recent 2 or 3 years, actually, our target is keep the common limb around 3.5 or 4 meters, because we found in Taiwan it will offer the best result for patients. So, okay, usually right gauge bypass is offered for patients in super obesity or diabetes with poor pancreatic function or GERD-C or even in Barrett esophagus. But for my personal thinking, I think it's the last choice. If I don't have another offer for patient, I will tell patient to do right gauge bypass. Why? For me, it's like just like a car, like a Rolls Royce. It's good, fantastic, safe, but in the long term, the maintenance fee is very high. So when surgeon offer this kind of surgery for patient, you need to tell the patient after a surgery, you need to keep a regular follow and take vitamin supply regularly. Otherwise, the malnutrition will happen in the future. So at least is a golden star right now, but I think it's good, really it's good. But problem is you need to know the defect in issue. In Taiwan, a lot of gastric ulcer or marginal ulcer happens in our hands. So result is good, but I think it's only a result. When we consider to the patient quality of life, you need to very carefully about this kind of operation. Another thing we offer is a DJB, duodenal general bypass with sleeve gastrectomy. So it's like just like a BPD DS inside the remodification or status operation. Usually in our center, it's a purely diabetes surgery. When the age the patient more than 50 years old or very poor pancreatic function with diabetes, mostly with the insulin use, we offer this kind of operation for them. It's good. So in the show, in the 2 years or even the 2 or 3 years result, nowadays Japan got the 5 years result. It offers very good anti-diabetic function for the result for patient. But the problem is it's not easy to perform. So usually we offer the patient not so obese one, more aged, more poor in pancreatic anterior function. But I think currently it's a good choice. But the last I would say is most important and my favorite surgery is PJBSG. This operation coming from Chile is from South America. Usually nowadays, we do less and less right gastric bypass. Why? Because of the coming of proximal general bypass of gastrectomy, this operation. If the patient need right gastric bypass, we will see if he's suitable for this kind of operation. If good, we will do operation to substitute for right gastric bypass. That's the reason we do less and less right gastric bypass in our center now. It's a good operation, but its composition is 2 parts. The one is sleeve in upper part. The second part is a brindle creation. So actually it's shortening the total small bowel length. So nowadays in our center, we will change the policy because in the beginning it's a fixed small bowel brindle is around 3 or 4 meters here, but nowadays it's different. Nowadays we do operation is a fixed common limb. So we will count the whole bowel length in the operation. If patient got a 8 meter, 9 meter small bowel length, we will only remain only 3 or 3.5 common limb here. And the connection is about around 20 centimeter from the child ligament. So we modify or adjust the situation, the brand of creation for patient, but we will always keep the common limb around 3.5 meters. I think this operation in our data result is as good as regular bypass does, and then the long-term care is very, very easy. So I like this operation. Okay, so for in the last, I think there's a lot of advantage and disadvantage about the metabolic surgery. So this kind of surgery could offer results that the medication could never achieve. And it could dramatically change the lifestyle, change the result, and change the life about patient. It could reverse diabetes. But problems, surgeon itself need to know the complication it may offer in the future. You need to let patient know in the beginning. So a lot of defect coming from the good part. So I think for surgeon itself, you need to very know the detail about what kind of thing you could offer. You need to warn the patient in the beginning and take them well. So in the last, I think it's about it. So for surgery nowadays, it's not only about the remodification about organ. I think it's a remodification about the brain and the lifestyle. So when we consider the result good or not, I think the result is patient could change, have a new life, and for a long time or not. If not, you have to do something better, improving your treatment you offer, the service you offer. Your purpose is change your life, how patients live, how they live, but not only a single operation. Okay, so surgery is only a part of the therapy, but I think a good cycle about excellence is about you need to have offer a patient team education and offer clinic and offer a good medical data application. All these kind of things could help you do your job well and offer good result. And also just like Nindy says, your team need to have emphasize in a lot of parts and make your result good. Okay, that's my talk. Thank you.
Thank you so much, Dr. Madsen. I think that was a really wonderful and very elaborate talk. And I do agree with you that I think just like obesity, metabolic and bariatric surgery is also a very complex science, and no one size fits every patient. And I think there are many variations depending on which part of the world we are living in. So we need to acknowledge that and accept that and move forward. So it was an amazing lecture. Thank you so much. And I think there are a few questions for you, but we will take them after Dr. Abhishek's talk. And we would now move on to the next talk by Dr. Abhishek Katakwa. It's my absolute pleasure to introduce him because we belong to the same alma mater and we know each other for more than, I think, 2 decades now. So Dr. Abhishek, he is the Associate Director of Center for Obesity and Metabolic Therapy at AIG Hospital in Hyderabad. It's one of the most well-known hospitals in the country. He has many publications to his credit. He is also an editorial board member of the Journal for Bariatric Surgery by our society in India. He has also authored many chapters in books, and he has numerous publications in prestigious peer-reviewed journals. He has special interest in metabolic surgery, and he is also a committee member for the IFSO APC Library Committee. So welcome, Dr. Abhishek, and it's all yours now. Thank you.
Thank you so much for your introduction. And it's always been a pleasure to learn new things. And Dr. Aparna has always been a source of motivation and inspiration for all of us. And I hope my screen is visible.
Yes, it is, Abhishek.
Yeah. So after the enlightening talk of Dr. Nidhi and Dr. Matt, most of you must be super excited, highly motivated. And my job is to bring you back to the reality, the real scenario in this world. And I shall be talking about the word of caution and how not to burn your hands in your bariatric practice. So to win a medical malpractice lawsuit, one must generally prove either of this. Healthcare provider failed to act in accordance with accepted medical practice, or it has caused a significant or permanent injury to the patient, or it has caused injury or death of the patient. And if any of these things happen, we don't want this picture appear in newspaper, because it not only spoil your reputation as a surgeon, but it also takes away your years of credibility which you have built over a period of time. And when you look at the internet, it's full of information. This family wins a lawsuit against a bariatric surgery of 5.9 million. And you know the reason was? The gastric leak went undetected for months, causing death of the patient. And why bariatric surgeons are more vulnerable when we talk about this bariatric surgery malpractice? Because the public awareness is not there. Even doctors do not know. I've known a lot of doctors who don't know about bariatric surgery. They still think that it is a cosmetic procedure. And a lot of them deny this procedure to the patient because they still feel that this surgery is very risky. And it's relatively new surgery. We know that it's maybe 2 or 3 decades old. A lot of people still think that it's a cosmetic procedure, so they don't want to do it. There is unrealistic propaganda done in order to promote this surgery, which is very unfortunate and shouldn't be done. There are very less certified training programs for the doctors so that they can't be trained. There is lack of standardized care and protocol. There is limited or no insurance covered for this bariatric surgery. Sometimes patient has to pay high cost. That's why there's more liability on the surgeon. There's disparity on the price. And unfortunately, the most important is media reporting. We have been observing this. If any of such media reports come, suddenly the number of procedure goes down if there is any bad news on the bariatric surgery. So let's go back to the literature and see what literature says about this medico-legal problems. So let's see a paper published in 2007, which says that 42% of surgeons had less than 1 year of experience of bariatric surgery in 100 malpractices claims against bariatric surgeon. The second point is 26% of the surgeons have done less than 100 cases in their lifetime. Surprisingly, 69% were AS/MBS members, so that's a good number, but still 42% surgeons had less than 1 year of experience. Procedure-wise, the most common procedure which was in the lawsuit was RYGB, and there was no mention of LSG and gastric band because it's a very old paper. Mortality, when we see that 53% patient died, major disability was seen in 7%, minor disability in 12%, and full recovery in 28%. And in 28 of 100 cases, potential negligence was found. Now look at this data, which is very important. The most important point was 82% patient, there was delay in diagnosis of complication. In 64%, misinterpreted vital signs. In 8%, there was technical error. So look at the technical error part, which is very less. Now in 15% patient, there was a dropped button phenomena, which means that the primary surgeon operated and the left arm for some reason, and the transferred coverage was immediately to the other surgeon, and the other surgeon who took care of the patient couldn't diagnose, couldn't communicate, and there was inadequate training on the part of covering surgeon. In 22% of these lawsuit cases, there was no comprehensive consent form. In 23%, there was non-compliant of perioperative recommendation, then something related to diet, then some few reasons related to follow-up. And in some cases, there was fraudulent billing also. And when we look at the complications which happened to this patient, the maximum was leak, which was in 52%, followed by 33% had abscess. And the most common allegation, if you see, is always the delay in diagnosis, the most common reason. Now, the other paper published mentions about the area of litigation in bariatric surgery. The first thing is faulty patient screening and education, delay in recognition and treatment of complication. We have already seen that. The technical errors are less common issue, whereas the inadequate training, hospital or the office staff is not well trained is very important reason, because it can carry an important weightage here. Inappropriate credential and deficiency of informed consent. There is another review of 140 medical legal claims, which again mention the same thing: delay in diagnosis or management of complication in the post-op period in 47% of patients. The most common was anastomotic leak. Death was reported in 50%, and in 47% patients, the judgment went into the favor of the patient. Now, what is the message which we get after seeing all these review from the literature? I tell you, being a bariatric surgeon is very easy. It's not a problem. All of us eventually learn the art of surgery, but the problem comes when you land up in a problem and when you see a picture like this in one of your patients in the post-operative period. That is a time when you have the worst nightmare of your life. So believe me, that is a time when you really want to tell yourself, do no harm if you cannot help. So if by your bad luck or by an unfortunate event, if you have any of these patients who have leak or any complication, the first thing you should do is ask for help. Do not hesitate to ask for help thinking that what people might think about me, people might judge me for doing something like this or why it happened to my patient. So the complication rate is going to be the same, whether it happened in first of your case or it happened after the 1,000 case you have done. If you're lucky, you may not have, I wouldn't say you're lucky. If you're well-trained, you have all the things, whatever has been covered in the previous talk, then probably you may not have these kinds of situations. But if by chance, if you have any of this situation, the first thing you should do is seek a help from any of your colleagues, because today's patient is a well-read patient. He knows the long-term and short-term complication. And I believe honesty is still the best policy if you practice in the pre-operative period. So no unrealistic expectations should be brought into the mind of patient when you're talking to them before surgery. You should tell them everything very honestly, including the complication and other things, because if God forbid and anything happens to them in the post-op period, they should be well informed about it even before the surgery. So here comes the role of protocol-based practice, which I call standardization of bariatric and metabolic procedures. So let's go back and rebrush all the points which have been mentioned in the previous talk. Obviously, multidisciplinary team is the most important thing, and the learning curve of the team is also very important. Bariatric surgery unit setup has already been covered by Nidhi well in detail. Choosing right patient, following the guideline has been mentioned in a very proper way by Matt, and choosing the optimal procedure is also be an important point. Don't be a stakeholder, don't be a sleeve surgeon or a bypass surgeon. Don't be a choose the procedure which is optimum for that particular patient. And when we talk about the consent, it is the information given to the patient. It is a documentation and information of documentation and documentation of whatever information you have given to the patient. Detailed clinical and lab testing is also very important. No post-operative surprises to the patient. That has to be covered in the counseling. The pain management part has to be covered. The enhanced recovery after surgery protocol has to be followed. The post-operative diet plan has to be told even before surgery so that the patient doesn't get surprised when he or she is asked to take liquid diet for 7 days or 15 days. Tell them that they might have some pain for first 24 hours despite of giving proper analgesia, so that they don't have that fear of having a leak or any other problem in the post-op period. Try to convince them in a pre-op period only that they should walk within 6 hours of surgery for enhanced recovery. A detailed discussion about the complication. Now, what is the right time to talk about complications? I tell you, if you tell your patient in a very first meeting about the complications of bariatric surgery, I'm sure that patient will never turn back to you. So first develop a rapport with your patient in first few initial meetings. And once you have a very good rapport, you develop a doctor-patient relationship, then probably a day before surgery, before signing the consent form, you talk to them, because by that time they will have a lot of confidence upon your skills. They might have already seen your reviews, they might have already seen your YouTube, or they might have visited your website, and by that time they must have already gained confidence upon you. Tell them about hair loss, loose skin, living with side effects. Tell them that they don't want to be from being overweight to malnourished, so that they are particular about their nutrition and their post-operative supplements. So counseling is an art which you gain over a period of time, which you learn by yourself. A doctor-patient relationship is a key to the success of any surgical fraternity. Risk versus benefit of surgery should be explained to the patient, because a lot of time patient might feel that, why should I undergo surgery? I am just obese. So tell them that what can happen to them if they don't get surgery done, because what the future which you can see, they may not be able to understand. So the best practice update for informed consent, it's very important. And I'm going to cover a few important points which we have already discussed. The short-term and long-term complications have to be explained. The potential for weight regain have to be explained to the patient. Inform them the long-term data about any procedure. And if it is unavailable, tell them that there's no data available for long-term for a particular procedure. The long-term benefit of weight loss should be explained to them. Tell them that not all pre-existing medical and psychosocial consequences of obesity will improve with weight loss surgery. There might be few things which may still persist, like in diabetes drugs might come down, or patient may shift from insulin to oral hypoglycemics, but don't make any false promises just because you want to operate on those patients. Patient expectation and the risk has to be understood. The behavior and dietary changes have to be understood. Quality of life is a substantial way, like some patient might have some gastrointestinal symptoms or nausea or vomiting after surgery. That has to be mentioned in the consent form. Evaluate each patient's comprehension of the risk, benefit, and consequences to the weight loss surgery. Now, when we talk about the intraoperative part, you might come up with some intraoperative surprises. Maybe a patient have grade 3 fatty liver, and you just went inside and found that there is ascites, or the liver doesn't look good. In that scenario, please abandon the procedure, come out, talk to the patient, and plan accordingly. Just don't do surgery because you have taken patient inside the theater. The standardized steps should be followed, right from patient positioning. And I remember when I started my career, in the very first day, the anesthetist could put all the possible tubings and lines. The list was endless. But over the period of time, they gained confidence upon my skill. And now we do the bariatric surgery just with one intracath, and we don't put any of these tubings, because more tubings are the reason for delayed recovery. Important point about the bougie, who handled the bougie? So when I started my career, I used to put the bougie and then go back and to handle bougie. Always ask anesthetists to manipulate it. Surgical steps have to be very much standardized, right from the surgeon position to, so that the whole theater get used to your protocol. I always record my video, surgical video, for future reference. I can go back and check from the very first patient till now. I have CDs of all my patients. Immediate post-op analgesia is of utmost importance. The surgeon's perspective, the ASM-based criteria for a bariatric surgeon is they should have participated in at least 100 weight loss operation. And they have, in case of non-fellowship, the documented training have to be approved by bariatric surgeon. A few words about the bariatric surgeon. I don't believe, in fact, ASMBS has changed the criteria. Now, the number of procedures are not a criteria. It's a quality which is more important, because a high volume center might impair the doctor-patient relationship, thereby increasing the likelihood of subsequent litigation, especially if the operating surgeon is buffered from spending time with the patient. And interestingly, ASMBS has moved from, and they don't no more consider volume as a criteria for recognition. Now, enhanced recovery after bariatric surgery, everybody speaks about it, but I'm going to tell you in a nutshell, what are the components of enhanced recovery? In a pre-operative period, optimize the patient for all the comorbidities. If the patient has sleep apnea, make sure that the patient uses BiPAP machine and do a proper gas analysis before surgery, do an ABG, and make sure that patient does not have any problem. Counsel the patient and family, shorten the fasting time, because now we allow clear liquid up to 2 hours and solid up to 4 hours before induction of anesthesia. Intraoperative pre-medication, parallel teamwork, awake positioning, standardized anesthesia, non-invasive monitoring, and short-acting anesthetic agents, avoiding any kinds of tubes and catheter and drain if possible. In the post-op period, proper analgesia, early mobilization, early oral fluid, thromboprophylaxis, which is very important, a discharge planning, follow-up, and a telephone call is mandatory for all patients. Now, what practice we have developed over a period of years is institutional protocol. We have a AIG hospital protocol for bariatric surgery, where all the documents from admission to discharge to follow-up are predefined with case-based modifications, so that it's more like a tick. You know, what we follow is airline industry protocol. The error is very less in the airline industry, because everything is protocol based. Every step you have to cross and you have to get it ticked. So that is how you don't miss anything. And we put continuous efforts to improve our standard of care. We regularly update our protocol depending on the recent literature and recommendation. We always have a multidisciplinary board meeting before scheduling any complicated cases or any revision surgery. We also have a mortality meet in case if there is any mortality due after bariatric surgery. We make sure that we try to go into the detail of it and find out why it happened, because it is important as a part of hospital audit. Now, I'm going to give you a few tips to avoid burning your hand in bariatric practice. The first, training, infrastructure, equipment, and a multidisciplinary team. If you're going for a war, you just can't go like that. You have to be well prepared. Your team has to be well prepared. There should be a great coordination among the team members. The recommended criteria for patient selection must be met. And at the same time, I totally agree with Matt. Using just BMI is not sufficient. And there's a lot of discussion going on now to include the metabolic factor. But so far, we have to still follow the old guidelines, whatever is there. And the preoperative screening, evaluation, and medical clearance should be done in all patients. A comprehensive medical and psychological evaluation is a must. Educate your patient, re-educate your patient in the pre-op, post-op, during the hospital stay, and during the various stages of recovery and dietary progression. Long-term follow-up is of very needful. The patient signs a contract that covers post-operative behavior and acknowledge their responsibility in maintaining their health, because they should develop that insight and a willpower to make sure that they get best out of surgery. Involve the patient's relative, involve the family, because they will play a very important role in post-operative period. Now, I would like to end my slide with these three prominent figures: Michael Jackson, Anna Nicole Smith, and Hulk Hogan. You know what is common between all of these? All of them went into malpractice lawsuit and claimed that their doctor or the hospital somehow damaged their health, and all of them have won a lot of money out of this court hearing. So I would like to end my talk with this message that bariatric surgery is something which is gaining a lot of popularity nowadays because we know that COVID is affecting a lot with people with obesity. But at the same time, one should understand that bariatric surgery is not like a gallbladder surgery or an appendix surgery. There's a lot to understand. One need to understand the metabolism, the physiology of the human body, and then plan your patients accordingly, because none of us would like to have any kind of such accidents in the beginning of career, because that can spoil, that can demotivate you for lifelong. Thank you so much.
Abhishek, thank you so much. That was a really excellent talk. And I must say the points you raised are very valid, and they fit in very nicely with the talks we had with Nidhi and Matt. So thank you so much. And I hope the attendees have learned a lot how to be careful. And it was a really, really informative talk. Thank you so much.
Thank you.
So with this, I would like to start the question and answer session. So Matt has already answered some of the questions in the chat function, but I'll start with that anyways. And please feel free from other speakers to add your experience or the expert panelists as well. So one of the questions was from Satkuman Mark. He asked Matt about tailored or standard limb lengths. Which one is better? Matt, you have kindly answered yes. Would you want to elaborate on your answer before anybody else wants to chip in?
Actually, there's something interesting. Actually, we changed the policy about the tailored length, about the power length. I think some study criticize about rural gauge bypass is not as good as the mini gauge bypass does. But I think when you look back the study, in the beginning, the rural gauge bypass, the bypass limb is fixed, is short, maybe 70, 80 is not so long. But you know, when we counted this small bowel in our patient, usually when the patient got obese, they got a 6 meters, 7 meters, even 10 meters bowel length. So we gradually changed the policy. So in the beginning, like Dr. Huang, you use a fixed 100 bowel length bypass or rural gauge bypass. Then adjust elongated BP limb every 50 according to the BMI. But nowadays, in the recent 2 or 3 years, we found, I think maybe the key point might be the common limb. In Taiwanese diet and lifestyle, we found in Taiwanese, the common limb will remain around 3.5 meters, may be a sufficient length for our patient. That's because when the bowel got a normal function, you need the bowel, it got food and the get juice, the digestive juice inside. All these 3 things come together, then this means this bowel got fully function. So we think in our practice now, just like we do regular bypass and do the PJB, we try to keep the length in the last. So we found it's good. No severe diarrhea, good in the long-term vitamin supply, and that quality is quite good. So in the beginning is a short limb, then we tailor it with elongated BP limb with the BMI. But finally found maybe if in proper BMI, maybe in Taiwan is the similar, the common bowel is very similar. Okay, so my answer is about it.
Okay, yeah, no, thank you so much, Matt. Any of the panelists want to comment on that? Or the speakers? No?
I'll just pitch in a little bit over there. Earlier, even when we were doing RYGBs at our center, we were also following the standard short BP limb length. We used to keep it at around 80-90 centimeters, never exceeding that. What we did find was that sometimes patients would have a little bit of inadequate weight loss with that, and they were never really fully happy with the results of their metabolic procedure itself. What we've now started doing is that we've started tailoring our BP limb length, and we keep it at almost around 140 to 150 centimeters. And we count the whole small bowel limb length as well. Sometimes Indian patients can have really short limb lengths and really short intestinal lengths. So if we find that the common channel is going to be anywhere less than 4 meters, then we reduce our BP limb length, and we normally land up keeping our alimentary limb fixed at around 80 to 100 centimeters.
Okay.
So
Yeah,
once again,
thanks.
this is where you need to just keep collecting all your data and everything, so that you can just build up on your own results and tailor it to your own cultural preferences.
True, true.
I
Now,
would just like to,
yeah, Aparna.
sorry.
No, go on.
I'd just like to add a word of caution here, because if somebody is just starting into bariatric surgeries, counting the entire bowel length may not always be an easy task in a very obese patient. So you've got to be very, very careful when you're doing that, because there can be inadvertent injuries which you may miss, and then it can actually lead to more harm than good. So maybe not really, until you've really mastered your surgery and crossed a certain number of cases, I think till then to follow a standard would not be a bad idea at all.
May I just add something? Okay, Abhi, you go on.
No, I was just saying that it's a very valid and an apt point what Dr. Aparna said, because doing no harm is the most important thing.
True.
Yeah, certainly. And
Yes.
I guess that there's more and more evidence. I mean, the thing that we love about bariatric surgery is that it is something niche, and there's still so many things that we are discovering along the way. And now we know that bile acid itself, its metabolism, its absorption, and its effect on not only on weight loss, but also on diabetic resolution is tremendous. So I would say probably the BP limb length is getting more and more important rather than the alimentary limb length that we thought probably in the past. So that's why I guess more and more is being paid, attention is being paid on the tailored limb length in this era.
Right.
Yeah.
Yeah, no, I think I absolutely agree there with all of you, especially with Aparna. And as Nidhi said, you can always start with standard limb length, and if the required result is not achieved, then you can always alter the limb length. That is possible. So counting the whole bowel, small bowel length is not the easiest of the tasks to do. Shall I move on to the next question? There was one more again, I think, from Jahangir Ali to Matt. And Matt, you have answered that briefly in the chat. Is sleeve gastrectomy with fundoplication for GERD and hiatal hernia. And you've answered that again. You want to elaborate on that?
It's really not easy, because in this kind of operation, you need to keep some part of fundus. And also when you do the dissection to the shortcage area, actually kill some blood supply. Because in our center, CK, my boss, CK Huang, I think I follow around 6 or 7 operations like this, but it's not easy to get a slim tube and also with a good fundus and do the suture. So I know in our patient, when we do this kind of things, that's because patient got severe GERD and he want to have some weight loss in the same time. Really, it's not about he want to have weight loss and resolve his GERD. It's different. I said it again. Usually we do this kind of operation for patient got severe GERD, but in the same time he want to have some weight loss. Not for the patient want to have weight loss first and improve GERD in the same time. Because we found it's trouble, not easy, and you could not have a very solid, compact gastric tube, and it's really damn hard, really. You don't want to do it frequently. But it's good. Yes, patient web developed operation, he said, hey, in the short term, the GERD improved a lot, but we got a patient after 2 or 3 years, this still complain about when it got busy or in stress days, the GERD still happened again. So I think still not a very purely very definite resolution for this kind of situation. Okay.
Thanks, Matt.
That's what we experienced.
Yeah. Anybody else wants to chip in? Any other advice? No. I would just say one thing. My preference would be to do a Roux-en-Y gastric bypass if that is not contraindicated. If patient has got GERD, has got a hiatal hernia, we know, I think somebody again mentioned in the chat function that the Fundoplication results are not very good in these patients for anti-reflux as an anti-reflux procedure. So I tend to use Roux-en-Y gastric bypass as an anti-reflux procedure as well as a weight loss and metabolic procedure. So unless it is contraindicated for some reason, I would avoid doing a fundoplication with sleeve. No experience in this procedure. Hands up, yeah.
What about sleeve with just a chorioplasthy? What is your experience? I mean, for patient who is not so heavy, probably BMI about 35 to 40, he has with a small hiatal hernia with probably just a class A to B esophagitis, and patient is not keen for RYGB. Would you just consider a sleeve gastrectomy plus a hiatal hernia repair? I guess sometimes in this group of patient with weight loss, probably their GERD may resolve. What do the panel think about this?
For my thinking is about that. Actually, the pendoscope before operation is very important, but actually it will not tell you all the stories. For surgeon, when you get in, you need to check the hiatus status by yourself. Sometimes when you get in, you find that there's adult adhesion, the weak cruise muscle inside. So I think in the recent 5 or 10 years, what I learned is when you get in, you want to do the sleeve, you have to check it. You will find you patient got a weak cruise. It's better to do some exploration and fix it, make the defect smaller. Because in the past, around 4 or 5 years, we already routinely do the fixation. Actually, when we in Taiwan, when we do the sleeve gastrectomy, we will do another ankle and suture to fix the ankle hits to the left side cruise together. We use Prolene or acetone to fix it. But in after 3 or 4 years, still some patient after this kind of fixation still got hypertonia presentation. It happened because we do the pendoscope, we do the CAT scan, we found the intrathoracic migration happens. So I think in the recent year, my personally believing is when you feel the patient with operation, when you feel the patient got a trouble in about a cruise, weak cruise, it's better to fix it in a shorten it in the beginning. It might be better. So I think hypertonia is an issue. That's the reason in Taiwan, your patient got GERD C with hypertonia, we will still do the sleeve-based operation, but we have to make sure we have to close it and fix it, make it better. So the current policy we do. But for barrage, it's not very careful, but it's better to not do sleeve-based patient for patient. Okay.
If you allow me, Kelvin, to elaborate on this issue concerning reflux and sleeve. Actually, there was 2 randomized controlled trials comparing patients who have hiatus hernia repair versus not, and the outcome in terms of GERD was the same. So, my approach for patients with hiatus hernia, first, I don't over dissect the hiatus unless it is really big. Number 2, if the hiatus is wider than 4 centimeters, then I do the repair, not to avoid reflux, but to avoid migration of this into the chest. So for the technique that David Noka is doing for the sleeve and fundoplication, really it is we don't have really a long-term data till present. We know from a report published like 10 years ago from a professor from the States, Professor Hawasti, doing the Nissen sleeve, the outcome was not good in terms of excess weight loss at 3 years of follow-up. So really we should be very cautious on choosing new procedures unless it is really done under IRB approval. Otherwise, we stick to the standard of care, which is for esophagitis to go for Roux-en-Y gastric bypass, and for small gastritis or whatever, we can do the sleeve.
I think most patients actually agree if you explain to them properly about what they will expect if, the right procedure is not done. I think 99% of your patients will agree to a procedure if explained properly.
I think communication is really the key out here. Like Dr. Aparna said, you really need to sit down with the patient and discuss all your endoscopy findings in detail with them and explain to them what would be the impact of a sleeve on their reflux and what will be the impact of RYGB on the reflux. Sometimes you will end up getting these patients who are going to tell you that, no, I may be having severe reflux, I may be having a big hiatus hernia, but please do not do a bypass because I want to go back the way God sent me down here. Many patients do not really want massive changes in their GI anatomy, and you'll be really surprised in day-to-day practice. There will be many people who will come up to you and say such things as well. So just have a very open discussion with these people, and probably you'll be able to find out a good middle ground there.
Should we move on to the next question? I think we have a question from Dr. Edward Cheong. He's asking about smoking and cessation and reducing alcohol intake pre-op in the ERAS. So Abhishek, would you like to take that?
So usually we recommend all patients to quit smoking at least 15 days before, because it's been proved that the nicotine gets cleared very slowly if you check in your blood nicotine level. So we usually recommend at least patients should stop smoking 15 days before surgery. But in all practical purposes, we see that these patients, they are addicted to smoking for so many years, and it is very difficult for them to give up on smoking at a very short notice. But we ask them to reduce it slowly. We give them some tips, the psychological tips. If they buy cigarette packets, we ask them stop buying cigarette packets, so that for every single smoke, they have to walk all the way to the place, buy a cigarette, smoke it, come back. It's a very time consuming process. So we try to do some kind of psychotherapy with this patient so that they stop smoking. Obviously, alcohol is not recommended. But in a post-op period, we ask them they can have occasional wine, a non-fizzy drink, which is not aerated, but that is very occasional, and that too after 3 months of surgery. But smoking, it's not recommended. Not everyone follows the recommendations, but we strictly ask them not to smoke.
Would anyone else want to chip in?
I would just say, add one thing. I think it's difficult to be absolutely certain whether they have quit smoking. So we in the UK generally have a policy not to offer bariatric surgery to smokers. So even when they are referred from there, so all patients come referred from a general practitioner here. So one of the criteria is the patient should have stopped smoking at least for 3 months before ever they are even referred. The other thing is, I would be very careful in doing a bypass for a smoker. If there is even a history of smoking, I won't do a gastric bypass, because I've seen the worst complications, marginal ulcers, stenosis, and all sort of problems in smokers. So my preference would be, even if they have a history, they say, look, I've stopped smoking 2 years ago, still I would think of doing a sleeve for them unless there is a contraindication.
All right. I think there is another question from Dr. Milana. It was something about titanium allergy, whether we can offer endoscopic sleeve to patients with titanium allergy. So I'm not sure how you would find out if somebody has titanium allergy. Any inputs on that?
I never heard anybody having titanium allergy. I don't know. This is a most inert material. That's why it is of medical grade.
And I guess we would only find out after the surgery, not before. So.
No, patient might develop some kind of reaction in form of, I remember a few patients have this tendency of, fibrosis or something like that, but we can't predict it preoperatively.
Correct, unless they've had some kind of implant before. Yeah. So any input on whether gastric plication could be an option as an alternative in such cases? I guess it can be, probably. We can do the best that we have at the moment.
But again, unfortunately, this is something we'll only find out post-op. So.
Yeah. I think there is one more question from her, which is, do you have experience with safe, Titan-free or probably titanium-free stapler magazine? I am sorry, I don't get the question.
I think it probably is titanium-free stapler, I presume. Again, but I'm not aware of one. So no.
You know, in Taiwan, maybe Kevin or Abhishek may know. In Taiwan, actually, my boss CK ever do a stabilis gastrectomy. He used the ligature to cut stomach and do the whole stomach suture. But don't do that. It's not easy, really. Recovery is good, really good. But
No,
you will drive you crazy.
I would
Abhishek, you know that?
Yeah, but in that scenario, if I find preoperatively any allergy or something like that, I would rather go for laparoscopic gastric curvature plication. That would be better than doing a butcher surgery like what Matt is describing. So I think all the questions have been covered, and there is no more question left in the box. I would like to thank, first of all, TUGS for getting all of us on board for this excellent session. And I would like to thank Dr. Bridge, Dr. Aparna, and Dr. Fawad for taking out time from their busy schedule. I know there's a lot of difference in the time zone, and it's almost night here, and I'm still in the hospital.
Oh, no.
So, and I also would like to thank Matt and Dr. Nidhi for, though Nidhi was not keeping well for last 3-4 days, and we were worried whether she would be able to join us or not, but she made all the efforts to come and did a great job here. Thank you, everyone, and over to you, Kelvin.
Thank you very much. Again, a big thank you to all of you. The three speakers and of course the three panelists, really a big thank you for joining us today. And it is really an enlightening session that we have and a very fruitful discussion. So as usual, before we go, just a few more announcements. Number one, an e-certificate will be given to you via your email. Okay, and a feedback form will be sent to you via email as well. Please respond to us so that we can improve in the future. And lastly, just to promote TUGS to all of you, if you are not yet a TUGS member, feel free to join us. It is free of charge for the membership, and you will enjoy so many, a wide range of academic activities that we are having at the moment. We have TUGS Lounge now, we have a Scientific Sunday, we have a TUGS Asia Symposium, and now we're going to have the upcoming TUGS Women Symposium as well, and also TUGS Africa Symposium, TUGS Spain Symposium. There's so many things that we can do together, and of course, we can collaborate together for future research and organizing a workshop and fellowship, etc. Right, so a reminder to all of you, next month, again, the last Saturday of the month, we will have the 6th TUGS Asia Symposium. This time will be hosted by the TUGS India coordinator, Dr. Vikas. He will be talking mainly on advanced gastric and also COJ adenocarcinoma. And again, I'm sure he will prepare a great team of faculty to update us on that topic. With that, I wish all of you a very good Saturday and have a nice weekend and stay safe. See you. Bye-bye.
Thank you.
Thank you so much.
Thank you.
Bye.
See you, everyone. Thank you.
Bye-bye.